Are you ready, Dr. Morato?
Yeah.
Okay, let me introduce you. Today, I have the pleasure of introducing to you Dr. Marcelino Morato, Trauma Surgery Fellow at Ribeirão Preto Medical School, University of São Paulo, Ribeirão Preto, Brazil. Thank you so much.
Thank you. So thank you everyone for being here. It's my second time presenting a case in this meeting. I'd like to thank you, my attending and chief, Dr. Godinho, who wasn't able to be here, unfortunately. He's the director of trauma of our unit. It's the emergency unit of Ribeirão Preto Medical School, affiliated with the University of São Paulo. Dr. Godinho is also the president of Brazilian Trauma Society, and I'm a third-year fellow in the same institution. I'd like also to thank Dr. Marcos for this opportunity. I'm going to present the case entitled One Bullet, Two Cavities. First, I'd like to show our trauma room in our institution. Is a level 1 trauma center. We have 169 hospital beds, 30 intensive care units, and 6 operating rooms. And here in these 5 beds, is where we deal with the major traumas we receive. So I'm starting presentation. We have a male patient, 19 years old. He was admitted in our institution after being admitted in our rural hospital first. 4 hours prior, he sustained a gunshot wound to the chest. And after he was transferred to our hospital. In the first survey, already in our institution, he was intubated. He had a right chest tube placed. There was 640 milliliters of blood. He had bilateral breath sounds. His pulse oximetry was 97%. His blood pressure was 90/60. His heart rate was 114. And his fast exam was positive in the right upper quadrant, in the left upper quadrant, and pelvis. His GCS was 3. His pupil was equal and reactive. And he had an entry wound in the right posterior axillary line at the 9th intercostal space. There was no exit wound, and they postulate that there was a posterior anterior trajectory of the bullet. This was the X-ray from admission. You can see the chest tube placed here and the bullet on the left of the midline. And after this presentation, I'd like to ask everyone, what was your first thoughts and what would you do now?
Thank you, Dr. Morato. Dr. Cassim, do you have any comment?
Good morning.
Good morning.
Good afternoon. This is a young man, 19-year-old, and he's got 2 cavity injury. The bullet is lying on the left side. He was shot on the right side, and he was resuscitated appropriately by having a chest tube placed, IV lines placed, and I'm hoping that they would have given him a little bit of fluid and got blood cross-matched, and hoping to give him more blood rather than fluid. And they did a chest x-ray or abdominal x-ray at the same time. And you see 1 bullet on the left side and the gunshot wound was on the right side. So that means that it has traversed the mediastinum, and the bullet is lying on the opposite side to the entry. And he's in shock, so I think I would appropriately resuscitate him with blood rather than a lot of IV fluid. And look at the chest tube drainage to see if it is continually ooze blood, and you have already evacuated 640 ml of fluid, and you should be thinking about taking the patient to the operating room, at least while you're resuscitating the patient, to see what cavity that you're going to enter, to do something definitive. As we all know, most gunshot wound to the chest does not require emergency surgery. Only 10% require surgical intervention. So one would be thinking about infradiaphragmatic injury. So resuscitation and continued evaluation of the patient and getting ready, at least contemplating to take the patient to operating room for definitive treatment to stop the bleed wherever he's bleeding from, most likely infradiaphragmatic area. If the cessation of blood stops from the chest tube. So I will stop there and let others chime in. Thank you.
Thank you, Dr. Kassim. Dr. Antrak, any comments?
Yeah, so I agree with all that. So based on the history and physical, the bullet, 9th intercostal space, and presumably going from posterolateral to anteromedial across the midline, meaning that it would have gone through the chest wall, through the lower part of the lung, directly across the diaphragm. Probably most of the blood coming out of the chest tube is from below the diaphragm, likely missed all of the great vessels by going more anteriorly. So you would have missed the infravena cava and aorta, presumably, if it did take that trajectory. So in this case, I would initiate a massive transfusion protocol, 2 grams of tranexamic acid, broad spectrum antibiotics, and then start to resuscitate him if he's a responder with a couple of units of blood. And there was a normal blood pressure, no longer tachycardic, and he's stable. At that point, I think it's reasonable to do a CT scan to see exactly what's injured. Otherwise, I would take him straight to the operating room to do a midline laparotomy, but prepping from the neck all the way down to the knees in typical trauma fashion.
Thank you, Dr. Antrak. Dr. Collet, do you have any comments?
Yes, I agree with all comments, but I think this patient may be transiently stable, so you can continue to resuscitation the patient using blood, and then you can go to an angio CT in this case. Sometimes you can't go to probably this patient has a diaphragm injuries and liver injuries. I don't know if there are some vessels, big vessels or not. The blood comes to the chest, maybe come from the liver. So I think in this moment, it's important to check the stability of the patients and can use in the CT to try to find if there is a activity blending anywhere or there is a big vessels or not. Because the probability of the diaphragm injuries, if the patient can be stable and the injuries may be only the liver, you can see in the CT, you can maybe no operation management, or can go to a laparoscopy and maybe treat the injuries by laparoscopy. And depends if you have injuries near the vena cava, near the vena porta, or other vessels, you can go to a midline laparotomy. Sometimes you think to put these patients aggressively to the laparotomy. If a patient maybe some parameters, maybe some stability, temporarily or not, maybe recover, I try to make an angio CT and decide if I go to laparotomy or laparoscopy to approach. Thank you.
Thank you, Dr. Collet. Dr. Fraga, do you have any comments?
Yes, I agree with our comments, but you need to take a decision. These patients took 4 hours to be transferred to the trauma center. 4 hours, it's a long time. And I have 2 questions to Dr. Morato. The first one, why they intubate the patients? Was problem because shock or the level of consciousness? Why was the intubation? Do you know, Dr. Morato, this information in the other hospital?
The patient was intubated because of the shock. Had not sustained any other injuries. He was the rural hospital. They didn't have any other blood products or anything that could help the patient. So because he started to become unstable, they intubated the patient, placed the right chest tube, and then transferred to us.
Excellent, excellent. The second question is about how many milliliters of crystalloids the patient received in the other hospital.
The patient received approximately 1 liter of crystalloids, but they didn't have any blood products, they start noradrenaline, then they transferred to us.
Okay, so 4 hours, 1 liter, 700 milliliters of blood in the right chest. I agree with Dr. Collet, maybe it's a liver injury and the blood is going from the abdominal cavity to the chest. Maybe it's a lung injury. Usually this injury stop the bleeding. And I think you are sure that's not a cardiac injury because the FAST was negative. The FAST was negative. And everyone knows that this patient needs a surgical treatment, in my opinion, a laparotomy, because in my opinion, the patient is still on shock, hypovolemic shock. So it's necessary a laparotomy, but some centers can do a laparoscopy. I think this is not a good patient to think for laparoscopy. And in my opinion, after give 2 units of blood and FFP, if the patient recover, he can go to the CT. I think the CT is important in this situation to choose which cavity open first. We start by the abdomen, or maybe there's a thoracic injury, you need to start by the chest. So for this patient, I think after 4 hours, I think you have time to give blood and wait the response to the blood, and if possible, go to the CT. So prepare the CT, prepare the OR. After CT, the patient needs to go to the OR because he has a positive FAST, and you need this information to maybe to take the best decision. But I agree with our previous comments. Thank you.
Thank you, Dr. Fraga. Dr. Hockman, any comment, please?
Yes, a few things.
Thank you.
First, I have some questions. You have 2 holes in the patient or 1? That wasn't clear to me. It was saying 1 hole in the posterior axillary line at
Only
the
one.
level of the 9th intercostal, but do you have 2 holes there, or I'm confused?
Only one.
Oh, only 1 hole. Okay, 1 hole, 1 bullet.
Yeah.
Mhm.
Oh, okay, okay. So, well, this is a thoracoabdominal wound. So you can have injuries above and below the diaphragm. You didn't do a FAST of the pericardium, or the pericardium was negative?
Was negative.
Was negative, okay. So, considering all this, you have a thoracoabdominal gunshot wound. Most likely, the bleeding is coming from the liver, most likely, and draining through the chest. Most likely, could be the lung, yes, it could be, but I don't see even a little bit of lung contusion there to suggest that the bleeding might be coming from the lung. So I think that the money is probably in the abdomen. This patient, 19 years old, systolic of 90 and a heart rate of 114, he's in shock. Initially, this low blood pressure could be because of sedation, because the Glasgow is 3 and he's intubated, so sedation can cause hypotension, but he's a little bit too tachycardic to attribute this to hypotension. So this patient is in shock, probably for under resuscitation. Has been 4 hours already. So the ideal scene is to resuscitate these patients in the operating room. 90 systolic in a patient with no head injury, 19 years old is probably okay. So this is a fine balance. Resuscitate in the OR or go to CT scan, go to the OR and start the resuscitation in the OR. This is what has been recommended, that this patient needs to be resuscitated when you are ready to establish final hemorrhage control. So I agree with Dr. Collet and Dr. Untrach. This patient probably, normally, you know that you need to operate on this patient, but because of the location of the bullet, probably having a CT scan beforehand will help. So if I have the CT scan, I can plan things better. If for any reason I don't have the CT scan and I need to go to the operating room, I will prep this patient from the neck to the upper thighs with both arms tucked next to the body and be prepared to do a thoracotomy if I need to do a thoracotomy. He might need a subxiphoid window, although you say that the FAST was negative. But this patient will need to go to the operating room because obviously he's in shock and he has bleeding in the abdomen. But I will try to do a CT scan first. The confusion was because I thought there were 2 holes, so my whole preparation here was completely different. But it's only 1 hole. That's it. Thank you.
Thank you. Dr. Morato, sorry, Dr. Cassini asking, why CT?
Why CT? Because in this case, you want to have an idea of the trajectory of the bullet. It's coming posteriorly. You want to see what lobes of the liver are involved. Maybe this patient does not need surgery. It has been well described in patients with isolated gunshot wound to the right upper quadrant that surgery sometimes is not necessary. So maybe he has a little bit of blood in the abdomen, but not too much. The blood is in the liver, and some of these patients might benefit from going to CT angio, angioembolization of the liver before going to the operating room. It would also give an idea. I think it was Dr. Cassini who mentioned transmediastinal. It could be transmediastinal. This is the location of the bullet is high enough that could have gone through the mediastinum. My feeling is most likely went through the liver, but if I have that information, might be helpful in planning the surgery. If it's a transmediastinal gunshot wound, the approach might be different. So if it's anterior, yes, you go through a median sternotomy. If the transmediastinal injury happened posteriorly, you need to be prepared to put this patient in a right lateral decubitus. We need to have double lumen intubation in case the bleeding might go from one lung to the other. So it might help you. So again, in trauma, we make assumptions many times because we don't have enough information. The safest assumption is that this patient will need, if he needs opening the chest, will be an sternotomy. But sometimes those assumptions are wrong. So if we can get more information before, I think is a good idea to have it. And this patient 4 hours later, you have it. Otherwise, the patient comes from the street with those numbers, I would probably never do a CT scan. Thank you.
Thank you, Dr. Hockman. Dr. Kassim, would you like to make any other comment?
I admire my colleague, the professor from Boston. He's 99.9% right, but sometimes he's 0.1% maybe different anyhow. So my concern here is the CT is not going to help me very much because I know the trajectory. You know, the bullet is on the right side of the chest and is lying on the left side. And he has obviously not injured any major vessels such as thoracic aorta or vena cava, otherwise he would be exsanguinating. But he's in shock, and he's in shock after 4 hours. That means he's in compensated shock. So in my opinion, a CT is not going to help me very much because I know where the injury is. More than likely it is intradiaphragmatic. So going to the CT probably will harm the patient than to help me in planning what I'm going to do. I already made up my mind that the money is intradiaphragmatic injury, and that's where I would go and avoid the CT because it is going to take up time and the patient may not do very well in the long term. That's my opinion, but I would like to hear other people.
Thank you so much, Dr. Kassim, for your comment. Dr.
Patricia?
Morato, your turn. Dr.
Patricia?
Frago?
Yes, from Campinas.
Okay.
It's very difficult to talk after these giant professors with a large experience on trauma care. But I'll try. It's a difficult decision. You can go to CT, it's dangerous, but 4 hours later, these patients in shock, grade 2 to 3, shock, haven't received blood. This patient needs to receive blood. So I think there's a time to take the best option. It's a thoracoabdominal injury. We don't know if this bullet will cross the mediastinum, if there is associated thoracic injury. We don't know. It's impossible to know only with this X-ray. So if possible, have the CT, you can plan the laparotomy or maybe the thoracotomy, the position of the patient on the OR. You can sometimes call other teams to support the surgical treatment of these patients, maybe liver transplant, maybe cardiothoracic surgeon. You don't know where's the injury. So if you have time to plan, I think it's good. If not, if the patients become more unstable, so go direct to the OR. But in my opinion, I think there's a time to try to identify where is the injury, because the CT is very sensitive to show us. And there's a question from Dr. Camilo, why not go to CT unstable patients? You maybe in 10 minutes, 15 minutes, you can have a CT. I know in Colombia, they have experience with CT in unstable patients. I don't like this idea, but they publish papers about this. So, and they have a large experience in gunshot wounds in Colombia, more than us here in Brazil. So this meeting is very important to learn with each other and to improve our decision. But let's go with Dr. Morato, because I'm very curious about what will happen with this patient.
Thank you very much, Dr. Fraga. Dr. Antrak, would you like to make any comments?
Yeah. I would just say quickly, there are two camps here, and different surgeons or in anything, physicians will disagree on the management of the same case. Doesn't mean that either of them is wrong. They could be both right. I think either approach here is okay. And if you choose to do a CT, you'd want to see if the patient's stable, or in fact he's stable at that blood pressure. But you can give him a limited resuscitation if he responds. Fine. If he doesn't respond or gets worse, then your hands are forced. So I think either would be okay. Neither is completely wrong. Either is a reasonable approach. Anyway.
Thank you, Dr. Antrak. Dr. Morato, your turn, please.
Okay, so this patient was indeed initiated a massive blood transfusion protocol, but he did not stabilize enough to a CT exam, so he was transferred to the OR. And indeed, they did emergency laparotomy, and the findings of the trauma team was a right diaphragmatic laceration. He had a liver injury in the segments 4B and 5, and he indeed had an inferior vena cava laceration near the duodenum, and in fact, an active bleeding there. There was no evidence of the projectile in the abdomen. They searched for it and did not find. They managed to stop the bleeding from inferior vena cava with suture, and also the diaphragm was sutured. The liver bleeding was controlled with compression and GF1. His cavity was drained and his abdomen was closed at this time because the patient stabilized. So after this management, they did in fact a CT exam that I'm going to show now. This is the axial film.
Inside the heart.
Sorry?
It's okay,
Yes.
Dr. Morato.
Oh, go ahead. Now you gave us the answer. Where is the bullet? The bullet is inside the heart. Okay.
So again, the axial film.
Tiro entrou na cava e subiu pro coração.
And I have not the coronal film. I'll play once more. And based on the CT exam, the patient was relatively stable. He was still intubated, but his abdomen was closed. The trauma team, they ordered an echocardiogram, which I'm gonna play now. This echocardiogram was a transthoracic echocardiogram. I don't know if everybody can see, but apparently the bullet is here. And the readings from the radiology team, I'm gonna show now. The CT, the readings from the radiology team was that the projectile was lodged near the diaphragm in significant contact with the inferior cardiac margin. And the transthoracic echo, they said the projectile was embedded in the myocardium of the right ventricle, and he had a small pericardial effusion. And now the patient is relatively stable. He was still intubated, his abdomen is closed, and these are the findings after this is the first postoperative day. I'd like to ask everyone, what's your next plan?
Thank you, Dr. Morato. Dr. Alex, can you hear me?
Vocês entenderam? Entrou na cava e subiu.
Dr.
Yes.
Alex,
Yes, can you hear me?
would you like to make any comment?
Yeah, sure. I logged in
Thank
a
you.
little late, but I picked up on what's going on. Dr. Hoyman, thanks for clarifying with your question the number of holes in the bullet, but it's pretty impressive. And this patient is still alive. And what would we do next with this with this bullet? I think this needs to be extracted. I know interventional radiology can do miracles. I'm not sure that they could do necessarily something here. It may be worth giving them a call or a chance to see if they can help with that. And if that's impossible, I think, or unsuccessful, because he has a small pericardial effusion, I think he may need to have the CT surgery involved to extract this, because the ventricle is going to continue to move, and eventually this is going to erode through and give a problem. If IR can take it out safely, maybe the effusion can be watched, because it's a low pressure system on the right, and he may be all right, okay with that. These are my comments. I'm curious to see what happens. Thanks.
Thank you, Dr. Alex. Dr. Fraga, can you hear me? Dr. Fraga? Dr. Fraga? Can you hear me, Dr. Fraga? Dr. Kassim, do you have any comments?
Very dramatic presentation. I didn't think that this bullet was in the heart from the chest X-ray. I should have suspected that, the way it was laying there. So the bullet now is embedded in the myocardium according to the radiologist. But is there a hole in the diaphragm as well? Is there a hole in the pericardium as well? I'm not sure. So did it migrate into the heart, or did it lodge into the heart? That's the question. So if it is migrated into the heart through circuitous route, and then I would probably consider interventional radiologists to have a go at it, and they can perform miracle like Dr. Alex says. You know, you can, I have seen radiologists go into a catheter and extract the bullet. But if the myocardium is injured, just extracting the bullet may be catastrophic for the patient. You know, he may start bleeding into the pericardial cavity and go into cardiac tamponade and arrest. So that's not a good idea. So I think my gut feeling tells me that I probably will require the help of the CT surgeon. And that brings me to the story of Dr. Trunky, who once had a bullet like this, and he went ahead and moved the bullet into the right atrium, and made an incision and grabbed the bullet and gave it to his assistant, and the assistant dropped it back into the heart. And that's a true story, by the way. So you have to be really careful and be vigilant and plan it carefully, how you're going to remove the bullet. And there are lots of tricks of the trades available. And you choose one which is best for you with the help of the CT, or the CT surgeon can do it himself. Thank you.
Thank you, Dr. Cassim. Dr. Fraga, do you have any comment?
Yes, can you hear me now?
I can hear you. Yes.
Okay, thank you. So very interesting, the case. I have some students and residents here. You were discussing about the case. I think I have the first answer. When it's possible, if you have a CT before the surgery, the CT can give us very important information, like this case. But the patient was unstable, so no CT, you need to go to the OR. But I learned a lot with this case, because nobody suspects of this trajectory of the bullet. It's very important during the laparotomy. There is only one hole in the cava vein, correct? Near the duodenum, Dr. Morato. Do you suspect about the embolization of the bullet during the laparotomy or no?
Yes, that's gonna see in the next slides.
Yeah, the suspicion was embolization, but if it was embolization, the projectile is inside the heart. Maybe there's a myocardial contusion, something different in ultrasound. But I agree with Dr. Cassim to call the radiology interventionist team. In my hospital, is the cardiothoracic surgeon used to do these procedures, or the cardiologists, they have more experience to work in the foreign body inside the heart. So and after the suture the cava vein, control the bleeding, only the hepatic bleeding, not so much the bleeding from the liver. Okay, and no duodenal injury. No duodenal injury. Okay, so now I think you have time to prepare for a interventional radiologist or cardiologist, where someone who has experience to remove this bullet in the heart. Congratulations, very interesting. And the students are asking me, oh, how it can happen. With bullet, you learn every day what can happen if you have a projectile inside the body of a person. Thank you.
Thank you, Dr. Fraga. Dr. Antrak, would you like to make any comment?
Yeah, yes, fascinating case. You know, seeing where the CT scan, it was really puzzling to figure out the trajectory, because then there's an entry wound in the skin at the 9th intercostal space laterally, and then there's a hole in the inferior vena cava at the level of the duodenum, so by the lumbar spine. The only explanation is that there's a bullet embolus, and it went back. If it's an embolus, then it didn't perforate the heart. It just embolized up into the atrium. So I would, and if that's the case, I think it's probably what they did is the interventionalist withdrew it from below through the femoral vein, but 19-year-old patient, And just, God forbid, imagine this was your 19-year-old son. Horrible to think about. What would you be comfortable with or uncomfortable with? I would call first the cardiothoracic surgeons at Dr. Fraga's hospital. They're the ones that would do either procedure. So, whether they'd want to do it in a hybrid room where they can quickly go on the pump and, or if they feel totally comfortable just taking the patient interventional radiology, I would be sweating until the bullet was out. But I'd go out on a limb and guess that that's what they did here. They went to interventional radiology, pulled the thing out, and then sent the patient home the next day, whatever.
Thank you, Dr. Antrak. Dr. Morato, your turn, please.
Okay, so I appreciate
Sorry,
that.
if I may, I would like to make a comment on this.
Dr. Hockman, I'm sorry. You
So
can
I will be the oddball here. And I would say definitely no interventional radiology. Absolutely no interventional radiology. There is an old saying, you don't call a child to do a man's job. In order to be politically correct, I would say an adult person job now. But this is very serious. You have pericardial fluid, which your only assumption you can make is blood. So however the bullet got there, it went into the pericardium and it started eroding into the right ventricle because of the movement, or it was embolized and now it's lodged in the wall of the right ventricle. This is very serious. This patient needs to be done surgically. If you try to remove this with IR, first of all, I don't think it will be possible because you need to put the basket that you need to retrieve through the tricuspid valve, which intermittently close. So it would be almost, I don't see how that can be done. But regardless of that, removing this, you can get into a catastrophic bleeding very quickly. So this patient needs to go to the operating room. We did a review recently that we submitted the abstract about what to do with intracardiac bullets. It's kind of like they're all case reports. It's very difficult to reach a conclusion based on what is published. But the movement of the heart, it will cause this bullet to move. Normally, when we leave bullets in plates, there is nothing moving constantly. The movement of the heart will cause the bullet either to come out of the heart or embolize somewhere or something. So this bullet, in my opinion, needs to be removed. I think the easiest thing to do is to do a median sternotomy and see where the bullet is. It's very possible that the bullet is just located in the pericardium and eroding into the heart because of the movement. If that's the case, that's great. You remove the bullet, repair the ventricle. I think the ventricle should be repaired, even though it might not be actively bleeding because the patient might cough, whatever, something might happen. And if it's inside of the heart, it's for cardiac surgery to put this patient on bypass and remove it from inside the heart. Embolization is rare. I had one case of a patient, a young patient, very skinny, shot himself with a BB gun in the right parasternal space, and the pellet embolized to the pelvis, always went through both chambers of the heart and embolized systemically, but it's possible that embolize. And this big bullet can embolize somewhere else if it doesn't kill the patient here. So I think that this is what needs to be done for this patient. This is something that needs to be explored in the images. As another thing, I had another case recently where the bullet was embedded in the wall of the atrium. The images, none of them was diagnostic of anything, and we have 3 CT scans through transesophageal echo. Is very, very difficult because of the artifact created by the bullet. The only way to know where the bullet is to go in and look for it. Thank you.
Dr. Morato, Dr. Cassini asking you in the end to share with him your presentation.
Of course.
Thank you so much. Of course, Dr.
Patricia?
Cassini. Hello, Dr.
Just a comment from Campinas.
Of course.
This why trauma surgery is very interesting, because this situation in my hospital, we call another specialty to discuss the case with us. Because I think for a trauma surgeon, it's very difficult to go to the heart, remove the projectile. But for a cardiac surgeon, they do something more difficult every day. So it's very important to call other teams. It's why you have a team approach on trauma care and have the best team option if interventional radiologists or go to the to a cardiac surgery to remove the projectile. I think it's very important to have a team in the hospital to discuss case like this one. Now the patient is stable, the patient is at ICU, you have more time to have one decision. Thank you.
Thank you, Dr. Fraga. Dr. Morato, please, your turn.
Okay, so yeah, I'm not sure if the radiation interventional radiology was consulted, but they chose to undergo to surgery, and their approach was on a median sternotomy. And the findings, for surprising of the trauma team, they did not saw any changes in pericardial sac and in the chest cavity. During the procedure, they called the intraoperative echocardiogram, who did not saw anything unusual in the heart. They did not saw the project that used to be lodged in the heart. So the team ordered a chest X-ray, X-ray intraoperatively, and this is the film. This is the rib spreader here, and this is the midline. This is the right side of the midline. And based on this exam, the patient is now with his abdomen closed, his chest is open. He's relatively stable, but he already has his chest open. I'd like to ask her opinion on how to proceed.
Dr. Fraga, please.
Probably the bullet is in the right ventricle or in the cava vein. Depends of the position of the table, the operative table, the projectile go ahead, go up, and go down with the cardiac contraction. So it maybe is inside the right cava vein, near the heart, because no injury in the. So it depends the position of the patients on the table, the operative table. If you put in the Trendelenburg position, the bullet go because of the height of the bullet go to the heart. If you put the just open up the head of the patient, the bullet go down. So you need to, I think now is easier, bring it to the right atrial to open and remove the bullet. It's a decision for the surgeon, a difficult decision in these moments, but it's sure the bullet is in the right vascular system of the patient.
Thank you. Dr. Antrak, do you have any comment?
Yeah, so let me just ask, is that on the right side or the left side? I assume it's the right side, but it's not marked. That's the right side?
Yes, correct.
Right chest.
Right side.
Okay, I would do, and you have the C-arm, I would do a lateral film. First of all, that's the first thing I would do to see where it is. And if you did a transesophageal echo right in the OR and it's not in the heart, and you should have been able to see the great vessels, transesophageal echo, at least down to the diaphragm. But I would do a lateral film, and if it's not in the heart, it's not in the heart. If it's not in the vena cava, one of the great blood vessels, I would, and if the lateral suggests it's elsewhere, I would leave it alone for now and call it a day. And then you can scan them again if you need to, follow it. That would be my approach.
Thank you. Dr. Kassim, do you have any comment?
one of the things that I have learned in my experience, when you have a bullet in the heart, the bullet never stays in the same place for more than X number of minutes. So the first thing you need to do is, before you embark any surgical procedure, you need to redo the x-rays, rescan the x-rays, and do a CT, do a C-arm x-ray, whatever facilities you have. In Los Angeles, they have a special x-ray machine that being used in South Africa under the diamond mine people, and they can get something done in a matter of less than 1 minute. In our hospital and in your hospital, you probably have a CT, you probably have a C-scan, some type of a scanning machine that is available in the operating room. You must do one before you embark on surgical intervention, because these bullets move. You know, I have seen a bullet which was in the heart show up in the carotid in a matter of 1 hour. And you look very silly opening the chest to retrieve the bullet while the bullet is in the carotid. In a case like this, if the bullet is truly not in the heart, then you need to assume it is probably in the one of the great vessels or somewhere. So you can either do a venogram to see if it is still sitting in the vena cava or bounce back into the vena cava, or lodged into one of the major hepatic veins. And that'll probably will give you the answer. Whatever it is, if it is not sitting in the inferior vena cava, you can leave this bullet alone for the time being and till the patient recovers completely from his shock and all the trauma that he has suffered. And then you can go after it at a later date. Thank you.
Thank you, Dr. Cassim. Dr. Morato, your turn.
Okay, so
Can I make a comment?
Sorry, you keep.
Can I make a comment? You skip me.
Yeah, can I make a comment too?
Yes. Okay.
You want to go first, Dr. Hoyman, or?
Oh, no, please go ahead. Go ahead.
I guess, you know, for me, at least the lesson would be for a situation like this to re-image before going to the operating room. I think maybe having different mindsets looking at this, maybe perhaps different ideas would have come up between different consultants. But I think with fluoro in the operating room, you could see if the heart is moving and this bullet is staying still now and it's away from it, then you have to figure out, did it maybe migrate through the atrium and now it's sitting down in the deep pulmonary artery in the lung, versus being down in the liver somewhere. And you're right, Dr. Hoyman, the read for these kinds of things in radiology, at least sometimes I see they kind of go through like indirect signs and they think they see an effusion, then they think they see this, then they maybe think it's embedded. So yeah, I'm curious to see what you did next, but yeah, that was my comment. Thank you.
Thank you, Dr. Alex. Any other panelists? Would you like to make any comment?
Yeah, I agree with the fluoro will be the ideal study here, because you will see if it moves, the movement of something that is intracardiac or in the wall of the myocardium is very different of something that is somehow floating somewhere. So fluoro will be the next step. But if you don't mind going back one slide, but I would probably, if I have to take a guess, if the bullet is in the pericardium, it's very difficult to find. I will make that pericardiotomy bigger. I will extend it higher up, almost where it has a reflection on the aorta, and I will extend to the inferior part to the patient's right. And when I have that, I will be able to lift the heart, because if I have to take a guess, this bullet is posterior to the heart. That would be my first suspicion where this bullet could be. Based on the CT scan that we saw before, it's possible to be in the IVC, yes, but I think it's unlikely that it will be floating in the IVC. So my guess would be that this is inside the pericardium, and I need to make sure that it's not there before going anywhere. In order to do that, you need to extend the pericardiotomy. You need to have a cardiac anesthesia, give you anesthesia, give the patient volume, put her on pressors, and very, very slowly and very gentle, lift the heart and see if the bullet is there. I've been there, and I've been in this situation that you cannot find the bullet, despite being a sizable bullet. It's very difficult to find there with the movement of the heart. But I would try to make sure that it's not inside the pericardium before going anywhere. Thank you.
Thank you, Dr. Hockman. Any other panelists would you like to make any comment?
Yes, I want to make a comment.
Thank you, Dr. Collet.
I think it's very important to know the trajectory of the bullet. You see that they says that the bullet was the posterior axillary line and go inside the peritoneal cavity. He transfixed the diaphragm, transfixed the liver, it transfixed the vena cava. So it's a linear trajectory of the bullet. And the bullet appear on the right and the left side. So what's the problem with the bullet? The bullet may go through the vena cava, and through the flux of the vena cava, go to the heart or near the heart. There is no pericardial injury, there is no cardiac injury. So the bullet, you can go to see the CT is one position, and you can go to the other position, you can see the bullet in another position. So they are floating in the vessels. So it's very important in this case to know the trajectory of the bullet to decide what to do now. If you are going to put the patients in OR, I think the bullet is in the right ventricle. I think I not go to start the surgery without a cardiac surgeon, because to open the ventricle, I need to put the patient in extracorporeal circulation. So I think it's very important not to avoid make injury, to avoid injuries if the patients don't have signs of blending of the myocardium through the pericardium. So I think it is very important in this case to know the trajectory of the bullet, and probably this bullet has embolia on the venous vessels, and they are floating in the vessels. This modification, the position modification can see the bullet only you have the X-ray. So if you go to the surgery, I agree. If you put contrast in a vena cava during the surgery, you can find the bullet, or you can call a radio intervention in this position and can take the bullet from the vena cava. So because the bullet you continue to migration in the venous system. Thank you.
Thank you, Dr. Morato.
Yes. Oh, I'm sorry about the image. The image wasn't so evident that this instrument here, if you can see this end of this instrument in the same image as here, you can see that the bullet is below this part. So wasn't so evident in my comments that the bullet was in the abdomen. So I'm gonna say what the trauma team did on that day. They chose to do a relaparotomy since the patient had his abdomen closed in the past day, and those were the findings that they found. There was no signs of the projectile in the abdominal cavity. The IVC suture was okay. You can see the IVC suture here. And they chose to do an interpretive ultrasound, which saw the bullet lodged in the right suprahepatic vein. So they postulated that the bullet enter to the vena cava, go to the right heart, and they come back to the vena cava and lodge in the suprahepatic vein. And I don't know if you have time, but based on the bullet lodged in the right suprahepatic vein, I'd ask if anyone have any comments.
Thank you, Dr. Morato. Dr. Collet, would you like to make any comment?
I think I have tell to take this bullet is in venous trajectory and then can migrate it. So in this position, that the bullet comes through the right to the back, it's not probably this bullet is the end of the bullet, it's the exit of the bullet. This is a migration of the bullet through the venous system. So I think in this position, you can stop the surgery and go to the endovascular. You can take this bullet out. That's what I think.
Thank you, Dr. Collet. Dr. Intl, would you like to make any comment?
Yes. So in this case, I think the bullet should come out because it can embolize. It's a venous embolus of the bullet, a low energy bullet, and two options: either interventional radiology if they feel comfortable, if you have them at your hospital. The other option, because the abdomen is open, it's in the right hepatic vein outside the liver, so you should be able to expose it through the laparotomy and then control the vein and remove it that way. It might be easier if you had a thoracoabdominal, but if you can mobilize, take down the triangular ligament and mobilize the right lobe of the liver and see the suprahepatic portion of the right hepatic vein and feel the bullet there, get control, remove, and then remove it to prevent further embolization. So depending on the options you have at your hospital, if you didn't have interventional radiology or they didn't feel comfortable, I would try the surgical approach.
Thank you, Dr. Intl. Dr. Cassin, any comment?
While you are inside the abdomen, you know exactly the way the bullet is. It is on the right side of the one of the two hepatic vein, and right hepatic vein is quite visible, extrahepatic. And you put two vessel loops and make a small incision over it, put a Fogarty catheter in and pull it out, and then sew the venotomy, and your bullet is out. Thank you.
Thank you, Dr. Cassim. Dr. Alec, any comment? Dr. Alec?
I think
Okay.
I think an ultrasound would be very helpful to see if you can locate the bullet exactly where it is, and then you can decide if you can get proximal and distal control of the hepatic vein with the vessel loop, confirm that the bullet did not move in between as you did that, and then decide which way you want to go, either make an incision and take the bullet out versus calling your IR colleagues. That's all I have to say. But
you.
I would not leave it there because it may move again and cause other problems.
Thank you, Dr. Alec. Dr. Fraga, any comment?
Yes, I think before opening the chest, the sternotomy, discuss the case with the cardiac surgeon and the vascular surgeon, interventional radiologist, because the suspicion was that the bullet was inside the cava vein or maybe at the atrium, and to choose the best way to remove these bullets. You need to remove. I think Dr. Cassim said you have the chest open, so you need to try to sew to the chest and not come back to the abdomen again. I think this was in the first or second day post-operative. So discuss with the specialty, because they have more experience to open the heart. For a trauma surgeon, for a gastrointestinal surgeon, opening the heart is very difficult, but for a cardiac surgeon, it's very easy. They do this every day and discuss the case and call the other team to help this difficult case, very difficult case anywhere. Excellent case. Congratulations, Dr. Morato.
Thank you, Doctor. Dr. Hockman, any comment?
No, except that I cannot understand how this is in the right hepatic vein when the bullet was on the left side of the abdomen or the chest in the CT scan and in the films. I really have no explanation how it ended up there. So I am very perplexed with this case. Thank you.
Thank you, Dr. Hockman. Dr.
Just,
Morato?
just a comment. Just a comment.
Okay, okay.
The
okay.
the ultrasound, the cardiac ultrasound, the Dr. Morato described with pericardial effusion and the bullet in the myocardium probably was wrong. It's difficult to when you have a foreign body inside the heart, but probably there was maybe a little pericardial effusion because the patient received a lot of crystalloids and was not consequence of a cardiac injury. Thank you.
Thank you, Dr. Fraga. Any other comment from the panelists? Dr. Morato, your turn.
Okay, so the trauma team was managing the case because of the time of surgery. He has his chest open, his abdomen open. They chose to leave the bullet in its position, and they performed abbreviated abdominal closure with a vacuum peritoneostomy. They chose to perform a conservative management of the bullet emboli, and they consult the vascular team, which said that therapeutic anticoagulation was not indicated for this case. This is the picture of the postoperative day. You can see the bullet now is in the right side of the midline, under the diaphragm, very different from the first position. And this patient follow up on the 5th postoperative day, he has abdominal closed. He undergo a prolonged course of interventions. He had the positive blood cultures. He needed a tracheostomy. He developed a new heart murmur, which he was on purulent pericarditis. He needed open pericardial drainage. He developed a ventilator-associated pneumonia. But fortunately, on the 26th postoperative day, he was extubated and discharged home on the 32nd. This patient is a regular follow-up of our clinic. The last time he was seen 9 months later of the first surgery. Control CT, there was no complications. The projectile was in the same place from the previous position. He had a lead level checkup, which was in the normal range. That is it. I just like to, if I have time, to say a little bit about bullet emboli, which was our diagnosis, which is most of them are due to small caliber bullets with relatively low kinetic energy, because the bullet has to enter only one part of the vessel, then into the circulation. First, there was thought that arterial emboli was most common, but now they postulate the venous are most common. The arterial bullets emboli are more likely to have immediate symptoms due to obstruction and ischemia, and advised to be extracted through endovascular or open surgery. The venous emboli, most common entry sites are the inferior vena cava, the femoral vein, subclavian vein. Eventually, they can go to the right chambers, and most of them travel with flow, but there is described some portions who go to retrograde secondary to gravity, which we believe was our case. There's also an entity called paradoxical venous emboli, which the projectile enters in the venous system, go to the right, and after cardiac defects or a traumatic arterial venous fistula, they go into the arterial system. There's controversial optimal management regarding venous bullet embolism to the heart, because most of them are asymptomatic. Some advise observations, and others advise removal because of the risk of pulmonary embolism, bacterial endocarditis, valvular dysfunction, or even cardiac erosion. And that's it. Thank you.
Thank you, Dr. Morato. Dr. Cassin, would you like to make final comments?
Fantastic case. Absolutely fabulous. I learned a lot from you today. Thank you for presenting.
Thank you, Dr. Cassin.
Thank you. Please, I share the CMA code on the chat. Can you please take notes? Dr. Entrak, any final comment?
Yes, fascinating case. So I suppose after a certain period of time, the bullet gets sequestered in a neo-intimal pocket, so it won't move. And then you raised a very important point that I forgot to think about. But when you have bullets that remain inside, creeping lead levels can be an indication for removing the bullet. So you have to remember to check the lead levels, but these have to be followed, I think, for years. Isn't that right? The lead levels for is it permanently every year or just up to a certain period of time afterwards?
I did not have undergo a literature review about that, but this patient had only one check.
Yes, but fascinating case, just brilliant, and is very lucky that the bullet went where it did, and he survived the 4 hours, and well taken care of at your hospital, at both hospitals.
Thank you.
Thank you, Dr. Alec. Would you like to make a final comment?
Thank you for presenting the case. There are many lessons to learn here. Yes, with the lead level, I don't know what's going to happen when this guy needs an MRI, but hopefully it will be many, many years down the road when enough fibrous tissue formed around the bullet. But again, thank you for presenting it, and nice to hear everyone's comments and experience with this.
Thank you, Dr. Alec. Dr. Collet, would you like to make a final comment?
Congratulations for the case. It's a very interesting case. I think the most important thing is to know how can diagnose the venous embolize. It's very important to know and how to try to fix it. Thank you for the presentation.
Thank you, Doctor. Dr. Fraga, would you like to make a final comment?
No, excellent case. I think it's necessary to follow this patient forever, because this patient can have complication because of these bullets. Probably they are in the outpatient clinics. And I think this case was presented by Dr. Scarpellini in a meeting in Portugal some months ago, because I was remembering a case like this one from Ribeirão Preto. I think was the same case, but was in the 2 months after the injury. Now we have 9 months. So it's a good case to discuss to a multi-institutional meeting, because maybe other centers, São Paulo, Instituto do Coração, maybe they will propose to remove the bullet. Nowadays, they change the tricuspid, mitral valve, everything by endovascular. So I think for them it's not difficult to remove a bullet. Congratulations for the case, Dr. Morato. Very, very good your presentation. Congratulations.
Thank you. I am sharing the CMA code for today on the chat. Please take notes. Dr. Hockman, would you like to make a final comment?
Yeah, great case. That's all. It was a great case. Very confusing for me. Thank you very much.
Thank you.
Thank you. Everyone, take notes of the CMA code for today. The number is on the chat. 114191. Thank you, all the panelists, for the excellent comments. Thank you, Dr. Morato, for the excellent presentation. We learned a lot. Thank you for accepting our invitation.
Thank you, everyone, for being panelists. Thank you, everyone. It was a great opportunity. And thank you for our comments.
Thank you. Dr. Fraga and Dr. Collet, can you hear me?
Yes.
Yes, sure.
Eu sou novo residente para o US General Surgery.
Oh, congratulations. General surgery?
Yes.
Yes.
Provavelmente Yale ou Texas. I don't know. Eu vou saber só na sexta-feira.
General surgery.
General surgery. Yeah.
Excelente.
Qualquer coisa que vocês precisem, estarei lá.
Tá ótimo. Parabéns.
Ué, tô
Obrigada.
reconhecendo essa língua que você fala aí, tô reconhecendo agora.
Essa língua boa, né? Mais um
Legal,
brasileiro na
parabéns.
residência.
Então
Obrigada.
vai sair de Miami, vai trocar de novo aí em Miami. Quem vai
Vou
coordenar as
começar a
reuniões?
residência. Vamos.
Residência é prioridade. Muito bom, muito
sim.
bom. Parabéns.
Obrigada. Thank you very
Parabéns.
much, everyone. In the United States, everyone have a great spring break. See you next
And
week.
yes, and congratulations once again, Dr. Patricia, Dr. Maya. I'm
Thank
thrilled for
you.
both of you. Yes.
Thank
Bye-bye.
you very much.